All right, good afternoon. Ooh, this is loud. We're going to start a little bit earlier than what's on your program. So if I may ask all of you to take a seat. We have a very brief presentation before we get started with what you see on your program. So you may have seen this person if you visited the different tables earlier today. So I would like to introduce Katie Marchetti. Katie Marchetti, who is a Society of Urologic Oncology Fellow at the University of Pittsburgh. She earned her medical degree and completed her residency in urology at the University of Michigan. Dr. Marchetti, Dr. Marchetti's research primarily focuses on advancing the use of technology to improve patients' interaction with the medical system as they navigate their cancer care. She is currently using remote monitoring with wearable devices to identify and treat early signs of complications following surgical removal of the bladder. She was one of the selected John Qualley Travel Fellows for this year's Beacon think tank. And she is here to present more about her research and ask for your help in further improving her work. So please help me and welcome Dr. Marchetti.
Thank you so much, Patricia. It's amazing to be here. I see many familiar faces out in the crowd, but for those who don't know me, my name is Katie. I'm one of the fellows at the University of Pittsburgh, and as was mentioned, I became involved with Beacon earlier this summer when I was invited to attend the think tank and discuss my research. As was mentioned, my research involves using wearable devices or Fitbits and smartphone apps to monitor people after they undergo surgical removal of the bladder during that vulnerable period. And I'm here to ask for your help. So in the hospital, after cystectomy, patients are monitored by an entire medical team. Doctors, nurses, every 4-hour vitals, sometimes daily labs, x-rays. But once they're discharged, nothing, silence. And as many of you know, the recovery after surgical removal of the bladder is very intense. There's a new normal that you and your family are adjusting to, and this is also why you try to heal from a major surgery. This period after hospital discharge, in my opinion, represents a blind spot in the way that we're caring for bladder cancer patients, and this is demonstrated by the high rates of readmission and complications after cystectomy. My research is trying to address this blind spot in the way that we care for people in the post-operative recovery period. As a surgeon, I want to hear from my patients after surgery. I want to know how they're doing, if they're doing well or not, so I can take action to help them avoid complications and issues if they're not doing well, and help them focus on the already very big task of just recovering and adjusting to this new normal for them. I am trying to do this with remote monitoring. First, a little bit about what remote monitoring is. Basically, it involves us using technology to keep a closer eye on people after they're outside the hospital. It involves a variety of mechanisms, smartphone apps, home blood pressure cuffs, activity monitors like Fitbits, as I mentioned. But ultimately, remote monitoring helps us quantify people's health status from home and may keep them connected to their medical team. In other fields of medicine outside of the bladder cancer space, remote monitoring has promoted very dramatic improvements in clinical outcomes, but the currently available remote monitoring programs after removal of the bladder have not, at least at this point, improved patient symptoms, rates of complication, rates of readmission. But as many of you know, the period after cystectomy is defined by very distinct characteristics and challenges, and thus I feel in need of a very intentionally designed remote monitoring program. The available programs that we use for remote monitoring at this point after cystectomy lack patient feedback. And here's lies what I think is the second blind spot in this space, which is the patient and survivor perspective. The absence of this perspective is a major flaw in the way that we currently remote monitor people and may contribute to the current lack of efficacy of these programs that's been seen in prior research. Over the last year, I have built a remote monitoring recovery program called Watch that some of you may have already heard about. This program incorporates the best of prior programs and innovates further by using wearable devices of Fitbit. And it helps us see patients' recovery in 2 dimensions, their symptoms and then their vital signs with a Fitbit. This program helps us define how people are doing after surgery, but it's really essential to ensure that this program fits the needs of people that are using it. By asking you, people with bladder cancer who have undergone cystectomy and your family members, about how I can develop a recovery program that serves people with bladder cancer, I will help address that second blind spot that I discussed earlier. What resources do people use after surgery? What do they find helpful and when? I need you to tell me so that I can connect people that are having their bladder out with those resources that you became connected to in your journey. The input of you and your families will be the backbone of this recovery program that I'm trying to build. To me, it just makes sense to approach it in this way. So how am I going to be doing this? I'm running guided feedback sessions with people to review the prototype of the remote monitoring program that we built. I'm asking for any and all feedback on the prototype. The feedback sessions, 30 minutes virtual, so you can do them from anywhere. We're not testing you, we're really just testing this prototype. All you need is a computer to complete these sessions. I'll take care of the rest. If you are interested in participating or even just learning more about our program, just scan the QR code. There's a link to sign up for one of these sessions, and then if you'd like to stay connected, there's a spot where you can enter in a little bit more information about yourself, and we'll stay in touch. I just want to thank you all for the opportunity to visit the Become Patient Summit, and thank you in advance for your assistance and helping me help my patients and hopefully a lot of other patients in the future. Please come say hi at our table if you haven't already. You can sign up there. My email address and my phone number are also below, so you can give me a buzz or an email. Thank you so much again. I would be happy to take questions as well if there are any questions about our program in general or about these sessions. Yeah, the question was, is the watch program used for a period of time after surgery? Yes. So data shows us that the 30 days after people are discharged from cystectomy are kind of the most vulnerable period. And so right now the program is targeting those 30 days. Eventually, it would be nice to have a program that kind of transitions people through some of the parts of their survivorship. So 30 days and then kind of maybe 30 to 90 as you're adjusting again to your normal, and then maybe kind of longer term. But right now, it's just those 30 days. Yes, so the Fitbit, we use the Fitbit to monitor heart rate, oxygen saturation, and temperature, which are probably the highest yield vital signs that we can get. The Fitbit's great because it's like a crock pot. You set it and forget it. You just put it on and it reads all this stuff for you. I'm a fan of ease, so that's incorporated into our assessment of people. And then the app has a feature where people can put in information about their symptoms. The symptoms and the vital signs are used to send me alerts if there's abnormalities and how people are all feeling. And then I call people to say, hey, I saw that you're pretty nauseous today. The degree of nausea you have is not normal. Let's talk about things that we can do to help manage your symptoms and hopefully avoid those potentially escalating to a problem that might require you to come to the ER or something like that. The question was about, can it monitor possible blood clot? So the oxygen saturation may potentially be able to detect if people have blood clots. Then we also ask about symptoms like leg swelling and things like that, which could be early signs of people that have blood clots in the legs. That's a good question. Yes?
In the future, if it's approved, who will pay for it?
That's a really good question. Who will pay for this if it's approved? That's kind of where I think that's where my role comes in the next few years. Right now, we're using this program in a clinical trial at University of Pittsburgh that's just trying to prove feasibility. Can we actually integrate this into care? But eventually, we'll need to prove that it's actually effective and figure out what signals remotely are linked to when people are having problems. I think once we are able to show that it's effective, I feel like it will be easy to get hospitals to pay for a program that can help keep people home, on the road to recovery, and out of the hospital with issues.
Insurance companies would be very interested in this
And that's true. Insurance companies would be interested in other spaces, as I taught, like continuous glucose monitors are forms of remote monitoring. Some of those are covered by insurance. Things like Zio patches that monitor people's heart rates and rhythms are also covered. So it has been done in other spaces in the past. Thank you all so much.
Thank you, Dr. Marchetti. Okay, let's see, time check. It's 1:24. And just so you guys know, Stephanie left me all by myself, so this is good. That means she trusts me. All right, we are running a little bit ahead of schedule, but I think it's great because the next session that we feel there might be a lot of questions, so we'll use that extra time if that's okay with you to get started. Yeah? Okay, excellent. All right. So before I introduce our speakers, what I am going to do is, this is the health and wellness in me. I'm going to ask you guys to put your hands to your side. I'm going to run you through a quick, just a relaxation to warm up your body and get you ready for this next session because it's going to be really good. All right, so hands to the side, roll the shoulders back just a little bit. 1, 2, and then 3. And now let's roll them forward. 1, 2, 3. Very good. Now bring those shoulders up to your ears. Hold them there. Hold them there. And drop them. Okay. Now take a deep breath in. Exhale out. Take a deep breath in. Exhale out. One last breath. And out. Now, last stretch. Take your right hand up above your head and reach for them apples up here, imaginary apples. All right. Okay, good. How far can you go? There. Now drop that hand. And now the other arm, lift them up and grab that apple. How many apples can you grab? Oh, I can see one. All right, drop them down. All right. Thank you for running through that exercise. We've been sitting down, and so I think it's good to kind of, loosen the muscles a little bit. All right. Thank you. Thank you, Howard. All right, so I used to be a fitness instructor as a hobby, so it's something I am very passionate about. So I have the pleasure of introducing our next speakers. Dr. Katherine Shapiro is a urologist specializing in urogynecology and reconstructive pelvic surgery. She treats female urinary incontinence, pelvic organ prolapse, neurogenic bladder, voiding dysfunction, and pelvic pain with medical and surgical options. Dr. Shapiro graduated cum laude from the University of Maryland and completed her urologic surgery residency at the University of Pittsburgh Medical Center, followed by a fellowship at NYU. She's now with Partners in Urology, part of the Robert Wood Johnson's Barnabas Health System. So I'm going to invite Dr. Shapiro up to the stage. You can give her a hand of applause. Thank you. Joining Dr. Shapiro is Dr. Saum Ghodoussipour, also known as Dr. G by his patients. He is a urologic surgeon specializing in cancers of the genitourinary system. He earned his medical degree from Temple University and completed his surgery internship, urology residence, and fellowship at USC and LA County Medical Center. At New Jersey's only NCI-designated comprehensive cancer center, Dr. G focuses on complex open and robotic surgeries, including bladder removal, urinary tract reconstruction, and nerve-sparing procedures. He is an assistant professor at Rutgers Robert Wood Johnson Medical School, actively publishing research and training future surgeons. Please help me in welcoming Dr. G. Both of our speakers today are going to talk to us about urinary and bladder health side effects post-treatment. They're going to explain what the side effects are, what causes them, and how they are managed. So with that, I'm going to hand over the mic to our speakers.
Okay. I don't know if I may have dislodged this mic when we were stretching. Can you hear me? Okay, no worries. Thank you for the introduction. I just first off want to say how much of a privilege it is to be here speaking to you all as a part of this meeting. This is my first patient summit. I've been to many of the think tanks and our other oncology meetings, but being able to speak with patients and hear from patients is really a privilege in this setting. So while we have some slides and we'll be giving a lecture, I don't really want this to be a lecture. Getting your feedback and having a little bit of discussion would be more important, I think. So yes, I do those complex surgeries that Patricia mentioned, but I also do a lot of non-surgical management in bladder cancer. Unfortunately, everyone who has bladder cancer does have to have at least one surgery, which is a transurethral resection. That's still an operation which has side effects, but thankfully, because of all the great work being done by the partners outside, we have a lot of bladder-sparing options, which can improve quality of life, but there are some side effects associated with that. So that's what we're going to talk about today. First, going over those treatments and their indications. I'll talk about the side effects, and then we're very lucky to have Dr. Shapiro, who is not an oncologist, but has a lot of expertise in this area as well. So I think we all know that the stage and grade of bladder cancer is really what determines the outcomes and the recommended treatment options. As Stephanie started with today's talk, there's over 80,000 cases diagnosed every year, and the majority of the cases that are diagnosed are non-invasive disease, so non-muscle invasive bladder cancer, which at that point is not a lethal disease, meaning we can treat it and essentially cure it. So there's a lot more people living with bladder cancer than the number that is diagnosed every year. And as you can see here, depending on the stage or the grade of the tumor, there can be very high recurrence rates, and there can be a progression rate, which is, that's our first job, is to avoid that progression, but also to try to minimize these recurrences. Those numbers are the reason that bladder cancer is the most expensive cancer to treat in the United States over a patient's lifetime. Over $5 billion a year are put into bladder cancer because of these recurrences and the surveillance and the treatment that's needed. So I think most everyone in this room is aware of BCG. Am I correct in assuming that? So BCG has been a standard of care in the management of non-muscle invasive bladder cancer for decades. It got its FDA approval in the 90s, early 90s, but the first clinical trials were done in the 70s. So BCG is literally the vaccine for tuberculosis, which is washed into the bladder via catheter. It gets taken up by cancer cells, and it leads to an immune response, which leads to killing cancer cells and preventing them from coming back. So 70% of patients will have a great response to BCG initially, and even if the cancer comes back, 35% of patients will respond to a second induction course. Unfortunately, after that, there's not a lot of benefit in giving further BCG, which is why there's so much research focused on the BCG unresponsive space right now, and why the FDA has put out the definitions of BCG unresponsive non-muscle invasive bladder cancer. In the past, if someone had BCG unresponsive non-muscle invasive bladder cancer, the standard recommendation was cystectomy, removing the bladder before you ever get to that point of progression to invasive disease. Now that still is an option and the right choice in certain situations, but these bladder-sparing treatments are becoming more and more effective, and that is allowing us to avoid major surgery in a lot of patients. You can see here a list of all the new agents that are under investigation or recently approved. So Adstiladrin and N803 in combination with BCG are approved, and you can get those treatments outside of a clinical trial. Bacretastimogene, TAR-200, EG70, and Gemdosi are all available to you on clinical trial. Gemdosi as a standard of care, but there's also some clinical trials, and these have all shown very good response rates, meaning over 50% at any time in patients with BCG unresponsive disease, a population of patients that in the past really had no good options aside from having the bladder removed. That's for high-grade disease. Low-grade non-muscle invasive bladder cancer is a whole nother sort of disease on its own with different biology and behavior, and there's some new drugs, including UGN-102, which is a gel form of chemotherapy that's put in the bladder And that's shown really good response rates early on. And like I said, there are some trials going on to replace BCG in the front line, namely gemdosi, which is 2 chemotherapies. Wash in the bladder is getting a lot of attention in this space with the ongoing bridge trial, which might sound familiar to some of you. The great thing about intravesical therapy is that overall it's very safe, right? This is a local disease that has not spread anywhere, so we have the option to give local therapy. That's not going to affect the rest of your body. Sometimes we need to give chemotherapy, we need to give immunotherapy IV to the whole body because that's what's required. But when patients present with non-muscle invasive bladder cancer, you could treat just the bladder and avoid any of those side effects that can happen elsewhere, like in the GI tract, the blood system or the skin, things like that. And all the studies of those agents that I mentioned on the last slide have had a 0 to 5% rate of serious adverse events. Now I'm going to get into a little bit about what the definition of serious is, but low-grade adverse events do happen in pretty much everyone. So it would be unfair of a treating physician like me to say that you get this treatment and you're going to do fine and everything's going to be okay and you're not going to feel anything. Because by definition, we're going to be doing something. And despite the lunch that we just had, there is no such thing as a free lunch, right? So if you get these treatments, you're going to tolerate some degree of side effect because of the benefit. So everything in life has a trade-off. But for the most part, we can keep these adverse events low. This is just an example from one of those new agents. I don't want to call anyone out, but just one of the drugs that has been tested. Serious adverse events, according to the NCI and drugs when they're getting FDA approval, is an adverse event that is grade 3 or higher. This is from the CTC definition, the common terminology for clinical adverse events is a standard scoring system put out by the National Cancer Institute. Anything grade 3 requires treatment in the hospital. Grade 4 is life-threatening, and grade 5 is something that does lead to death. Grade 1 side effects are things that can just be managed with observation. So you have some burning in your bladder or urinary frequency, but you don't take any medications. You just sort of ride it out and wait for it to go away. A grade 2 is something that you can treat with, like an oral medication or some other behavioral change. And you can see that with these agents, the grade 3 events are very rare. They can happen, but the grade 1 and 2 adverse events are very common. So most patients can expect to have some sort of grade 1 to 2 event, and even though that's not serious according to the FDA or the NCI, to all of you in this room, I'm sure that it is an important thing to consider. And that's what we want to sort of talk about today. Bladder-sparing therapy is not just an option in patients with non-muscle invasive bladder cancer. It is also an option in patients with muscle invasive disease. So a standard of care for muscle invasive bladder cancer is chemotherapy followed by surgery to remove the bladder. But chemotherapy and radiation combined with a maximal transurethral resection is also an option. And you can see here, this is copy and pasted from the NCCN guidelines. It's a category 1 recommendation for patients with muscle invasive disease. There's intricacies in determining if it truly is, the best choice for you, but it is an option that can allow you to keep your bladder, but there can be side effects associated with that. Again, you can see the CTC adverse events. Grade 3 is a little bit more common if you're getting chemotherapy and radiation, which makes sense, right? I say chemotherapy is a systemic drug. It's affecting your whole body, and radiation is a little bit different than intravesical therapy. The RTOG definition on the bottom part of that slide is much lower. That's a different grading system specifically put out by the radiation oncology community. And the difference with radiation compared to other treatments is that you can sometimes have side effects kick in later. So this is a study that looked at patients who had radiation, looked at late side effects 2 years after their treatment was complete. And you can see that there is some persistence of side effects, and sometimes side effects kick in then. But still, it's not extremely high. Grade 3 or higher events was in only 7% of patients. But you can see how common some of these are, and you can see what a grade 3 event might be. Severe frequency and dysuria, that means going to the bathroom a lot because you have a strong urge to do so. and having strong burning with urination, and having hematuria or blood in the urine, which I think everyone in this room has heard the word hematuria before. So these are all adverse events that are written down by a doctor or a clinical trial coordinator or nurse who is filling out questionnaires. But I think what matters a little bit more is what is happening to the patient. What is the patient experiencing? So Dr. Marchetti gave a very nice talk talking about patient-centered, patient-focused outcomes. So patient-reported outcomes are totally different than anything reported in these questionnaires that are recorded by a clinical trial coordinator. This is a statement put out by the European Association of Urology on what patients can expect after a 2-RBT. Bleeding, constant urge to urinate, discomfort, being tired. These are all things that happen. And as we have more and more bladder-sparing treatments, there's going to be more and more patients getting 2-RBT rather than cystectomy. And are we truly understanding the side effects that happen with these treatments, or are we potentially underestimating them by using these standard questionnaires? I think that what's more important to me when I meet with a patient is how they are experiencing things in their own journey themselves. So this is an example of a validated patient-reported outcome questionnaire in patients with non-muscle invasive bladder cancer that has a lot of different symptom scales and things that are reported by the patient, not recorded by a doctor or written down in a chart. This questionnaire, I think, needs to be used in more of the trials moving forward. Of all those new agents that I mentioned before, patient-reported outcomes have only been reported in 2 of the trials. One of the trials that did get FDA approval does have a nice study reporting patient-reported outcomes, but it's a rare thing reported. But I think that we all recognize that, and it's something that's going to be more common moving forward. These are patient-reported outcomes after chemotherapy and radiation for bladder cancer, not for muscle-invasive bladder cancer. And you can see that there is a pretty big hit with that drop in the first part of the figure where patient-reported outcomes do get worse, but after 6 months they get better. So I think a lot of physicians and oncologists will look at this and say, oh, everything gets better, it's fine, it's no big deal. But those 6 months matter to all of you, so I think it's something that we cannot ignore. So with that, I want to get on, hand the mic over to Dr. Shapiro, who's going to talk about the management of these side effects from a perspective that's not oncology focused.
Thank you, Saum. That was amazing. So I am here to talk about what we can do about this. And some of these options that I'm going to discuss are things that could be done while you're getting BCG, or things that might need to wait until after you're done with your intravesical therapy. So as Saum had mentioned, there are side effects with these intravesical therapies. Bladder cancer is unique, where you can give these therapies straight to the bladder, and that's a great thing. However, putting these agents in direct contact with the lining of the bladder has a lot of consequences with the inflammatory response within the bladder, as well as the lining of the bladder and the cells within the bladder and how they communicate also with the nerves that go up to your brain and how your bladder symptoms are throughout this process. So urinary urgency, frequency, pain with urination or dysuria, pelvic pain, just generalized lower abdominal suprapubic pain, these are all very common, can affect up to 70% of patients. And in all the studies, there's a range of 7 to 20% of patients may discontinue treatment because of these side effects. So although they are grade 1 to 2, they are not something to just brush over. If people discontinue intravesical therapy because of these side effects, there is a risk of disease progression and worse clinical outcomes. So whatever we can do on kind of the non-oncology side to make this more tolerable so you can get through that 1 year or 3 years worth of intravesical therapy that you need to get, just so that the patient outcome and lifelong expectancy is better. So why do these side effects occur? So the whole idea of intravesical therapy is you're creating an inflammatory response. And so you're increasing inflammation within the bladder. And anytime you increase inflammation anywhere in the body, it's not always a great thing. It's good for getting rid of cancer, but not necessarily for the overall long-term health of that organ. So increasing all of these inflammatory mediators within the bladder has a direct effect within the lining of the bladder and deeper into all those other layers of the bladder. Additionally, because of all this inflammatory response, the lining of the bladder is a bunch of cells that are all connected to each other. It's kind of like a mesh within the bladder. So what you're doing by having all these this inflammatory response is you're increasing the space between these cells so that these agents can actually get into the deeper layers of the bladder and affect actually the nerves. And that's where things start to get altered, is when these agents get to the nerves and actually lower your pain threshold and change your whole pain threshold response. This chronic inflammation also leads to fibrosis. So what that kind of means is you're creating scar within the bladder. So the bladder is supposed to be a nice floppy balloon. It's a low pressure environment that just passively collects urine. But when you create more scar tissue, it becomes a stiff bowling ball almost, and it can't stretch. And because of that, the overall amount of urine that you can hold in your bladder is decreased. So you're going to the bathroom more frequently, and it can also cause pain associated with that. And also, as I mentioned, that direct effect on the bladder nerves. There are lots of pain nerves to the bladder, and these get altered. And the studies really looking at this are not so much at patients who have bladder cancer, but really at patients who have chronic bladder pain, or something that used to be called interstitial cystitis. So it's a very kind of common pain syndrome that people know of, kind of that IC or interstitial cystitis term. All of these studies are really looking, you're almost creating a very similar environment to what these patients with interstitial cystitis have. So the pain threshold is much lower, and that has effects on your central pain system as well, within kind of the brain and spinal cord. So how do you treat this? So there are no specific guidelines in the American Urologic Association or the European Association of Urology for kind of quality of life after bladder cancer treatment. But everything I'm using is from other guidelines, whether they be recurrent urinary tract infection guidelines or overactive bladder guidelines or bladder pain syndrome. So that's where we really take all this data and we kind of adjust it to what you need and personalize it. But in general, this is really just symptom management. You cannot really reverse this process in the bladder. So the first thing I want to mention is something that's a little bit old school. It's not as common anymore because it's kind of in the narcotic class of medications, but belladonna and opiate suppositories are actually extremely good therapy where you're putting a suppository that essentially has anti-spasmodic qualities and also kind of narcotic and opiate qualities as well. So these are very good. These oftentimes would be given to patients right after a TURBT or a TURP to kind of help in that immediate post-operative period. It's not something that's usually used long-term, but it's something that's very effective. They can be a little expensive and they're a little bit harder to get because they are in that narcotic range now or narcotic class now, but they're very effective. The other thing I'm going to talk about is oral treatments, of which there are quite a few. The first one are overactive bladder medications, and these are very common. There's a lot of overactive bladder medications out there, and that's because overactive bladder is so common. There is about $80 billion each year spent on overactive bladder, and so a lot of patients who have had intravesical therapy can fall into that category as well of having severe urgency and frequency, and also having incontinence, so severe urgency and not being able to make it to the bathroom. So these oral treatments are very effective. There's two classes. One class has been around for many decades, and I don't love them as much because they tend to have a lot of side effects. The side effects can be dry mouth, dry eyes, and constipation, and there's now good data showing that long-term use of them can actually have cognitive effects. So I really try to avoid those, which is unfortunate because they're cheap and they're easy to get. But now because of this, there's a new class, and they're called beta-3 agonists. And there's two of them. There's Myrbetriq and Vibegram. Myrbetriq has this cute little guy. You probably have seen commercials of this cute little guy. It's a bladder that's kind of dragging the patient around everywhere they're going because the patient's controlled by their bladder. But this really works to try to relax the bladder. They're very good. They have very minimal side effects, if any, and they don't interact with other medications. These are things that you can give to patients while they're getting intravesical therapy. The only downside is they tend to be costly. So they can be expensive because they're newer, they haven't been around as long. Other just symptomatic treatments are just simple NSAIDs, Tylenol, Aleve, Motrin. You're trying to target that inflammatory response you're getting in the bladder. So naturally, NSAIDs are kind of a first-line option. Pyridium is something that's available both over the counter and by a prescription. It's also called Azo when you get it over the counter. This works by trying to kind of help with bladder pain in general. You can't really use it long-term, but it's good for kind of a spot treatment. It does turn the urine and other secretions orange, so that's kind of the biggest side effect and bother patients can have, and so you have to educate them on that side effect. But it can be very effective, and you can take it in kind of a higher dose that's available than what is available over the counter, and can be very nice for kind of a short period of time. Elmiron is a medication which is also known as pentosan polysulfate sodium, which became all the rage a few years ago with interstitial cystitis or chronic bladder pain. It was thought to be like the IC medication for bladder pain, and it was thought to kind of create this protective layer on your bladder so that nothing could kind of permeate your bladder wall. Unfortunately, they started to notice side effects with retinal changes in the eye. So that's a big side effect that can happen. Kind of the ophthalmologists started realizing this relationship between retinal disorders and use of this drug. So it's not as common anymore, but it is still available. And steroids are also a really nice option especially while you're getting the intravesical therapy. There are studies that look at giving the kind of a steroid taper in between your maintenance regimen to try and help kind of get you through that maintenance therapy. Once maintenance therapy or induction and maintenance has been completed, another option is intravesical, so continued intravesical therapies, but not with chemotherapy or immunotherapy. These are things that shouldn't be done while you're getting your induction or maintenance because there is a risk with these of kind of a bladder perforation or affecting the bladder in a way that you couldn't get your immunotherapy or chemotherapy. These, once again, are really used for bladder pain syndrome. So bladder hydrodistension is something that's done under sedation in the operating room, where effectively you're just filling the bladder up with fluid, either saline or water, and you're stretching the bladder out. This is something that doesn't last forever. It has to be done every few months, but it's something that has been shown to be very effective with bladder pain syndrome. The other thing is instilling hyaluronic acid. So hyaluronic acid is actually, I feel like, a very popular term now. It's in every facial moisturizer. It's in every plastic surgery office. But even instilling that into the bladder can help just kind of with kind of protecting against the inflammation. And then other bladder installations with lidocaine is something that's also very common. It also doesn't last long term, but it can provide immediate relief, just putting a catheter in and then instilling lidocaine into the bladder. So something else that can be used is hyperbaric oxygen. This is a little bit more involved. This is something that's usually done as an outpatient, but you're going to usually a hospital like for 40 treatments of this. This is something that's become very popular and common with wound healing or burn victims and also kind of radiation cystitis. So this is a therapy where it increases the oxygen amount in your blood and helps with overall healing. So this is very effective. It just involves a lot of time commitment to do this. But in those kind of severe cases where the oral medications or the intravesical therapies aren't working, hyperbaric oxygen is actually a really nice option. And then I just want to spend kind of 2 slides on urinary tract infections because these can also affect patients with non-muscle invasive bladder cancer. Once again, this is a guideline for recurrent uncomplicated UTIs in women. So a lot of things about the oncologic population are different than this. The urinary tract infections that bladder cancer patients get are by definition complicated, so they need kind of a longer course of antibiotics, and this affects men and women clearly. But some basic things that we can do beyond just treating each episode is doing some prophylaxis. So these are things that I think are wonderful There's supplements, they're over the counter for the most part. These are high dose cranberry supplements that are available online. Probiotics are good. A supplement called D-mannose, which is like a sugar that's supposed to help prevent bacteria from binding to the wall of the bladder, is very effective. Patients who are getting like really every month or every 2 months UTIs, I start doing antibiotic prophylaxis where there's a low dose daily antibiotic just to kind of break the cycle. So I do usually like a 3-month course of this. I never put someone on this for multiple years because it breeds resistance and has a lot of side effects with it. Additionally, in the postmenopausal female population, vaginal estrogen is the #1 thing we can do to help prevent recurrent UTIs. And what that does is it helps to change the environment within the vagina to promote good bacteria that's protective against UTIs. So this is something that is just definitely not utilized enough, and I am strongly in favor of it because it's not hormone replacement. It only works locally, so it's extremely safe to use. So who should you see if you start having a lot of these side effects? Of course, you'll see your oncologist first, but also general urologists are also seeing this. My specialty is urogynecology and reconstructive pelvic surgery. I see a lot of patients with kind of quality of life issues, incontinence, bladder pain. So I have a lot of familiarity with these treatment options, and so do the general urologists. The only thing that's kind of different about urogyn is that there's 2 routes to this, from an OBGYN or a urology pathway. So really you kind of want to focus on getting to a urologist because they know bladder cancer, they know the treatments. Even though they're not doing those surgeries, they're very familiar with it. So that's kind of who you might want to look for in your area. And thank you.
Okay. Is this on? Yes, it is. All right. Thank you for the presentation. We're going to go into the Q&A session. Just want to point out that we have Bernadette on that end with the microphone and Nick on that end. And again, this is to help us ensure that everybody can hear the question and so that also the recording can capture the question as well. So I see a couple hands up, and we're going to get started with questions from the audience just because I want to make sure we answer all your questions and I have some to follow up. Did I see some hands up over there? Yes. Can we get a microphone? Nick, right over there. Oh, sorry. I guess my glasses are not helping. All right, go ahead. Sorry about that.
Thank you. I was just wondering what's the typical length of time for these side effects following your BCG treatment? Like I had mine September 18th. I'm still having side effects. It seems like frequent urination, pain, etc.
Yeah, so the side effects from intravesical therapy can sometimes persist for 6 to 8 weeks afterwards, after you're done. And in extreme cases, it can be even longer than that. So, if you're just a month out, I think it's very within the realm of what's expected to still be having side effects. Now, radiation is a whole different story, but with intravesical therapy, once you get away from the stimulation in your bladder, things should calm down. That being said, the standard regimen for all of these is to go on with maintenance therapy. So, sometimes the side effects can be cumulative, or you're going to get intermittent breaks from side effects, but they will come back with each treatment. And again, though it may be worth it to tolerate a little bit of side effect for the benefit that you're getting, you want it to be within what you're expecting, so you're not surprised by it.
Where's Bernadette?
Hi. I had radical cystectomy going on 6 years ago, and I have a neobladder. And I've tried most of the things for frequent UTIs. I'm on cranberry supplements, I'm on probiotics, I'm on D-mannose. I just got off antibiotic prophylaxis, and one of the things I realized is I haven't been as regular with my estrogen as I need to be. But I'm now on methenamine, Hiprex. What do you think?
Your bladder is always going to have bacteria in it. So that's where it gets tricky, right?
Yes.
You're going to go to your primary care every year. They're going to get a urine, and even if you have no symptoms, they're going to treat you as if you have this horrible infection.
No, I go to my urologist.
Wonderful.
I live in that office.
Yeah. That is tough. So I have seen some patients who will get intravesical gentamicin, or like actually an antibiotic into the bladder.
Huh.
That's another thing, kind of an extreme case, but if the other options are all exhausted, long-term prophylaxis, like trying to do a longer taper for you. Methenamine is good. The data for methenamine is usually out of patients with neurogenic bladder, so patients who have some sort of neurologic insult, spina bifida, multiple sclerosis, spinal cord injury. But yet again, we use that and we apply it to different patient situations. So methenamine is good. I do want to stress that usually it needs to be taken with vitamin C.
Yeah.
Okay.
How much vitamin C?
Usually, I think it's 1,000 a day.
I'm doing 1,500.
Okay.
Okay.
See how it works.
Right. Thank you.
Of course.
Thank you. Who's next?
Hi, I'm Jerry Henderson. Ian, I have two questions. First is, you didn't speak about the nephrogenic adenoma, which I got after I've been on, this is my 5th year, and I've gone through 2 different series of BCG. And I was curious why you didn't discuss that.
Nephrogenic adenoma is one of the histologies. So, you know, that's, sorry for not specifically going into that, but in that low-grade TA population, there's a couple other different things that go into there. So that does fit in there, and it does have, you know, risks of recurrence. So you know, that's what you've...
So the second question I have is, a lot of the results of BCG continue. I mean, they haven't gone away. The urgency, the pain, also, it's, you know, like, I wish the app would have a place which shows me where to go to the bathroom. You know, all the places on a trip. Because it's, you know,
Could make a lot of money right there.
I know, they would. I mean, gas stations just tell me if it's a good bathroom or not.
Yeah.
But I was curious, is there anything naturally, something exercise, you know, you see so many supplements out there. I'm scared to use them because they probably don't work. But anything you guys seen in that area that you could do that would relieve some of the symptoms?
So you had mentioned exercises. So there is pelvic floor physical therapy. I'm not sure if you've heard of that, but it is one of the best things ever. So pelvic floor physical therapy is something that I feel like is the best hidden secret in the US healthcare system. For example, in Europe, every woman at 6 months postpartum gets a prescription for pelvic floor physical therapy to help prevent incontinence, to help just pelvic floor strengthening. And also that has long-term benefits for like pelvic organ prolapse. These are specialists who have pelvic floor certification. They're physical therapists. We are lucky kind of on the East Coast region where there's a lot of them that are around. In where I trained in Pittsburgh, they were few and far between. But they are absolutely wonderful. They have all these tips and tricks to help with just strengthening your pelvic floor, abdominal core exercises, pelvic floor, because your pelvic floor is made up of muscles. And so strengthening those muscles just like you strengthen any other muscle in your body. They usually determine how many treatments you get. It can be 3 or it can be 12 sessions, and you can keep doing it every year. So it's a really nice, non-invasive, low risk, no side effect option for patients with all sorts of pelvic floor disorders.
Right over here.
Hi, thank you. I think this is a question for Dr. G. Early in your presentation, you had a slide that talked about BCG's effectiveness, and it started off with 70% of patients have an initially good response, and then 35% after the second induction have a response, and then limited after. Are you saying, am I to read that as BCG over time, even if it may have proved to be quite effective over a 1, 2, 3, 4, 5-year effect period, it becomes less effective?
No, I don't think that that's the best way to interpret it, but I think that when you're talking about the outcomes of this drug, we need to talk about long-term durability. So BCG does have very good long-term durability, but beyond 2 years, 3 years, 4 years, 5 years, we're outside of clinical trial windows where these things are reported. So upfront to the induction, patients have a very good response, but there can be recurrences within those 2 years. If you make it out past 2 years and you're recurrence-free, the efficacy is not going to go away necessarily. You can still have good outcomes. So the standard regimen that has been a standard regimen without issues of shortage is to give BCG induction once a week for 6 weeks, followed by maintenance, which is that once a week for 3 weeks course. That has been studied in the US through the SWOG group, the Southwest Oncology Cooperative Group, and they have a SWOG regimen. I don't know if anyone's heard of that. So it's giving a 3-week course at month 3, month 6, 12, 18, 24, 30, 36. And so with that regimen, we found much better recurrence rates than if you just gave the 6 weeks. And in some of the modern trials, that 2-year survival from recurrence is over 80%. So if BCG isn't given adequately, then yes, recurrence rates can go up. But if you get it adequately, you get repeat induction when you need to, you get appropriate maintenance, then the recurrence rates are excellent. And the trial that's going on now in the naive setting, treatment-naive setting to try to replace BCG is randomizing BCG to gemcitabine and docetaxel. That's based off of data that shows that docetaxel has long-term success rates of around 80%. But that's in retrospective data, and that's with 6 weeks of induction and then 2 years of maintenance, which is once a month for 2 years. So there's little subtleties and whatnot. And if you get off schedule and things like that, that's, that can contribute to recurrences, but that's all outside of rigorously studied clinical trials. But I wouldn't say that your chances of recurrence go up over time. If you get your adequate treatment, there's a very good chance of success.
Thank you.
Yeah.
Who has the mic on that side? Okay, go ahead.
Yes, for overactive bladders, I was hearing my Betric, and I'm wondering about that versus Gemtesa.
Right, so
side effects.
they're in the same class. Gemtesa is the newer one. It's been around for about 5 years, I believe. It's not generic yet, whereas Myrbetriq is now generic. So the cost is a little bit different of the two of them. Myrbetriq's side effect is usually about 10% of patients might see a couple point bump in their blood pressure, and 1% of patients might have headaches. Gemtesa doesn't, they argue that there's no hypertension side effects. They still have kind of the same thing where a couple point bump might be seen as well. I still do think that's more tolerable than the side effects with the other class of medications. So I think I prefer that class.
Thank you.
And to
Yeah, so I have a two-part question, one for Dr. S and one for Dr. G. Dr. S, in terms of side effects, do you find the side effects vary dependent on the dose, the frequency, the duration of the BCG treatment? And for Dr. S, I don't want to get too technical here, but you mentioned adequate dosage and you mentioned the FDA, which came out with the guidance, revised guidance just a month ago for draft comments. And what was particularly troubling to family members and patients is that the FDA guidance says that for clinical trials, you have to start with which patients are unresponsive to adequate BCG treatment. And then it says adequate BCG treatment. It never defines quantitatively. And in fact, it compares adequate BCG treatment, undefined, with less than normal doses, undefined, and less than the number of treatments. And so the question for you is, you mentioned 6 induction treatments, 3 maintenance treatments. I think and please correct me if I'm wrong, what 6 treatments and 3 today is very different from several years ago, because the doses today are significantly lower than several years ago, and there are a number of places, very well-recognized medical institutions, that only give 5 doses and 5 induction and 2 maintenance, but they're full doses. And when I've asked for information about studies that compare the effectiveness of the 6 and 3 reduced doses with the 5 full and 2 maintenance doses, the responses are always, well, we all have in-house studies. So since a lot of what you said relates to adequate doses and staying with your treatment, is it really 6 and 3 lower doses, or is it 5 and 2 full doses? And that ties into, what are the side effects and what? So I'm sorry for the long question, but it's extremely frustrating to patients and families to see this government stuff come out, inadequate and less than adequate and no quantitative definition at all, and some of the best medical institutions in the country giving completely different treatments. A lot loaded in there, sorry.
Yeah, that is a great question. Who wants to go first? No, I appreciate your frustration. And, the government definitions are just guidance for these clinical trials and industry and how to get drugs approved. And they may seem annoying to have these government definitions, but they are allowing innovation in our field and allowing companies to develop new drugs. So they are very good for our community as a whole. Because we've got 2, 3, 4 coming up soon now, approved treatments because of these definitions. But I understand your frustration. So the new statement is a draft statement, and once it came out, there's a lot of people sending in edits and whatnot. So let's see how it officially plays out. But for academic or definition purposes of what adequate BCG is for the clinical trials, you essentially have to see BCG twice. So if you can get induction, and then you can get maintenance. And as you probably know from the original statement, it was at 2 out of 3 maintenance. Or you can get induction, and then 5 out of 6 of your next induction. So when you talk about people talking about in-house studies and whatnot, that sounds a little bit anecdotal. So I think most of us try to stay away from anecdotal evidence when we're talking about treatments and bladder cancer. We're going to talk a lot about anecdotal treatments tomorrow when we talk about recovery after these surgeries. But the reason that we use 6 treatments for BCG is because it came in a 6-pack back in the day. And that was not scientific. But since then, people have done studies to see, do we need to go to 6? Can we do less and whatnot? And they've decreased the frequency of maintenance. And that's where you run into trouble if you get a little bit too creative in trying to decrease the frequency. There's been studies looking at interleukins, inflammatory proteins that are in your urine after these treatments. And so Mike O'Donnell, I don't know if there's anyone from Iowa here, he's sort of the guru in this space. And it sounds like you're hearing from a mad scientist when he's talking about this stuff. But it's very well researched and thought out that after 5 treatments, that's when you get the best immune response. So you may be alluding to some people who stop at 5 because some old retrospective studies showed that 5 is all you need, but 6 has been the standard for a long time. So that's what we do.
Is that full dosage? Is that the same dosage of 6 treatments today as it was?
Yeah, so the full vials have been the same as they always have, but people now do split dosing. And we've shown that there is equal efficacy if you reduce the dosing. So it's not like this is a created drug with a certain number of milligrams and whatnot. This is, like I said, it's a bacterial culture that's grown. So each vial is a full down vial, and they try to make it the same. But if you do a half vial versus a full vial, the overlap in the number of bacteria and the species in there varies. So there have been trials, not anecdotal or in-house, specifically in Europe. There was a ECOG, cooperative group trial in Europe, which is like our equivalent of a SWOG, that randomized patients to 6 weeks of full dose versus 6 weeks of a third dose versus 6 weeks and 1 year and 3 year with full dose and third dose. And there was no difference in third dose versus full dosing. And there was no difference in 1 year versus 3 years in terms of progression, but a slight difference in recurrence. So that's why a lot of people now with the BCG shortage, they're cutting down that 3-year recommendation to 1 year. But for the most part, I understand that you've probably heard a few different things, but it is 6 weeks and 3 weeks for maintenance of BCG, and that should be the standard because that's what's most well studied and validated. With the newer treatments that are coming out, though, I think that it's going to be fair to ask this question because a lot of the drugs are getting 6 weeks based off of that old school six-pack data.
And with regards to the side effects of dosing versus duration, there's no data good enough and microgranular enough to determine that. Everyone's different on how they respond to the therapy.
Question in the back.
Yes, my name is Ron Douglas, and I was diagnosed back in 2011 with a non-invasive cancer, and I received BCG probably since then, maybe 30 treatments of it. By the way, just for grins, one of my nurses once told me that if you don't have any reaction to it, it ain't working. So for whatever it's worth, I don't know, old wives' tale or whatever that may be, but what happened was after about 8 years of this on and off BCG, it stopped working, and I went 18 months ago to Keytruda, which has worked beautifully for me, minimal side effects, but now I only get 2 years of this, and they're going to take me off of it, I believe. Do one or both of you fine doctors have experience with this immunotherapy, specifically Keytruda? What are you telling patients, or what happens to patients after a couple of years of this? Do we go cold turkey? Can we keep, or can we somehow get it for periods beyond the 2-year protocol? Or are you just maybe don't want to say? Maybe don't. I won't hold you to it. I don't know. You may have some secrets here that.
No, you guys should come to all of our oncology meetings. I think you bring up a lot of good points. But I didn't talk about systemic therapies or immunotherapies. But yes, Keytruda is one of the other FDA-approved options. We were sort of focusing on the treatments in the bladder, but Keytruda is effective, and some of the ongoing trials combining Keytruda with other agents have shown really good response rates. When you're on Keytruda, you potentially are putting yourself at risk of immune-mediated side effects, which are systemic. It happens in 10 to 15% of patients, which is why it's small, but if you have them, they are life-altering. So a little bit more of the enthusiasm interest is in intravesical therapies. But when we're talking about unresponsive disease that could progress to something lethal, you may want to escalate treatment, deal with potentially different side effects for that trade-off if it's worth it to you. In terms of the duration of treatment beyond 2 years.
My oncologist told me to ask you exactly that. Exactly that. Ask what the duration is, the operative word here. What's your recommendation?
Yeah, so the Keynote trial that got approval didn't do anything beyond that, so we don't know. It's an unknown space. And if you continue on this therapy more, you might be putting beyond that, potentially you're putting yourself at risk of those side effects happening because your risk does continue as long as you're on it.
Actually, that's exactly what he said to me.
So you have to weigh the pros and cons. You've had a great response. You're what, over a decade out now?
Well, yes. I mean,
but since
Keytruda started 18 months ago, I get another treatment every 6 weeks. So my last treatment is Christmas Eve, believe it or not. That's my last treatment of it. And then beyond that, if I could get it, I'd be tempted to run the risk of what you're talking about. Well, the risk is that there's some kind of immune response that's negative. Is that not correct?
Yes, you have a risk of getting one of those immune-mediated side effects as long as you're on it.
But what if I want to run that risk? What if I want to run that risk?
Yeah.
Would you recommend I try and get this? Okay.
On it. So it's a total gray zone, and you're asking a really good question. But I honestly, I haven't, not knowing your bladder and having been in and out there, I don't know how good it looks right now. I don't know what your initial grade and stage were and things like that. But if you're having those discussions with your oncologist and they think it's safe for you to stop, I am a big believer in not, treating if you don't need it, and just getting what you absolutely need. Because if you have a recurrence, you could do it again. In the past, it would have been scary to have a recurrence because the next step is removing your bladder. But there's so many options now, even going back on Keytruda. So drug holidays are something that are commonly used in patients with metastatic disease who are continuing on these therapies for the rest of their life, right? We've done this in prostate cancer. Now we're doing it in bladder cancer.
Okay.
I think it's a fair thing for you to think about continuing, but is it really worth it?
Thank you.
Okay. To the runners, could I make sure that you get more people from the center, please? Okay. Bob, you have the mic.
Hi, thank you. Two things for Dr. Shapiro. Number one, just wanted to echo what you said about pelvic floor physical therapy. How many people here have had PFPT? That's a good number, but not as many as I'd like to see. It has helped me significantly, and being a survivor-to-survivor advisor to bladder cancer patients, that's one of the first things that I say to them is get it done, before the cystectomy, so you have a baseline, and then get it done afterwards, so that you can recover as quickly as possible. I think it's a very important thing. So anybody who's advising patients here, I'd highly recommend making that part of what you say, and exercise, other things as well, before and after. The second thing I wanted to talk about and ask you about is I've had recurrent UTIs for several years. How many people here have had recurrent UTIs? A fair number. At my institution, they've had me bring in infectious disease expertise. So I just wanted to maybe have you speak to that as well. Is that something that you would recommend, is to bring in infectious disease doctors to help you decide, what can you do in terms of long-term antibiotics? What should you not do in terms of resistance? Thank you.
Definitely. Infectious disease, I think at each institution's a little bit different. The infectious disease doctors I work with tend to defer more to urologists for kind of the management of it. I think it's different everywhere. So when it comes to daily low-dose antibiotic prophylaxis, I kind of drive that ship when I'm doing it because I just feel that they don't want to do that as much. It just kind of varies with each specialist. I get them involved really when we're getting to the situation of multi-drug resistant UTIs. So I can't give oral options, or really the IV is needed because they can do infusions in their office and keep you out of the hospital and not getting IV treatment only in the hospital. So that's really where I defer to them, or if there's fungal UTIs and they need a longer course of like an antifungal. There's a lot of side effects with those medications. They need routine blood work while they're getting them. So that's where I kind of tend to defer or try to bring in the infectious disease doctors. I just lost my train of thought. But so it just varies, I think, at each institution with how comfortable they are treating just recurrent UTIs. And in a bladder cancer patient, I feel like an infectious disease doctor is going to really defer to the urologist more because it's a different bladder than they're normal to, and a different urinary tract than they kind of are used to seeing.
This is just a note in response to the gentleman who wanted to know where the bathroom was. There's an app for that.
I'm sure there is. There's got to be an app for that.
It's called Where is the Public Toilet? And there are 61 of them within 1 mile of here.
Yeah.
So it's an app worth having if you really want to know.
That's amazing.
2 years ago at this summit, they mentioned about a critical shortage of BCG, and they said that one company that manufactured it stopped manufacturing it, leaving only one company to manufacture it. And because due to the long incubation period to create the drug, it would be 2 years, which would be somewhere around now, that they get caught up to meet the demand. Has that happened yet? Or?
No, we're still dealing with the shortage, which is why people are splitting doses, so that you can treat more patients with one vial. So it's still an issue, but that being said, we are very actively, trying to develop alternatives to BCG. So the ongoing bridge trial, and then all of these new agents that I highlighted before, are all sort of expanding into the treatment-naive space to see if you can do these drugs instead of BCG. But yeah, we're still dealing with the shortage, and me being at an academic center, I get a lot of patients sent to me who are getting BCG out in the community by doctors who say, oh, I don't have BCG, can they come to you? Because as a cancer center, we have it, but then it's going to start putting strain on us. So almost everyone in the academic community is having contingency plans and of who they're going to give BCG to, how long we're going to give BCG. For example, my center has moved away from 3 years of maintenance to 1 year of maintenance based off of that European data.
So this is for Dr. Shapiro. You didn't talk a lot about incontinence. The pelvic floor therapy helps a lot, but is there anything specifically one can do for nighttime incontinence? Like every time I fall asleep, it's like if I'm watching TV, sitting there, and I doze off, I have an accident.
Yeah, so the nighttime issues are very hard to treat in non-cancer patients and in cancer patients. So it's a whole behavioral thing, trying to reduce, reducing fluids, emptying your bladder before you go to bed. There are also some medications that are like there's pills or nasal sprays which try to reduce the urine production at night. It actually targets the kidney. One is called Nocturna or desmopressin. They tend to come with a little bit of side effects. They can kind of disrupt like electrolytes, and so you have to have blood work when you get them. But those can be pretty effective. So trying to just even overall reduce how much urine you're making at night. Trying to reduce if you have lower extremity swelling, elevating your feet a few hours before bedtime to try and reduce that swelling. Trying to avoid all of that extra fluid off before you go to bed. The medications can help. They tend to work day and night. There are other third-line overactive bladder medications like bladder Botox or nerve modulation devices, but those tend to be a little bit more invasive. So trying some behavioral things and these kind of medications to target the nighttime things are really what's out there right now.
So is it still up? Oh, yeah. What's the physiology that on the production of urine at night? I mean, it's like my understanding as a geologist is that it's going through your blood and taking out the excess liquids, and is there anything that you can do to kind of work with that?
So it becomes more common as you age to have to get up at night. So someone who's in their 60s or 70s, if they're getting up once or twice a night, that actually is that's almost normal as you age to not sleep the whole way through the night without getting up. So your physiology kind of shifts where you make more urine at night. I don't have a great explanation as to why, but usually getting up once or twice a night as you age becomes normal. There is a very, very strong link also between obstructive sleep apnea and making more urine at night as well. So a lot of patients I see who, their spouse complains that they snore all the time and they kind of wake themselves up with a jolt. If they actually get a sleep study and get a CPAP or a BiPAP, they can go from getting up 7 times a night to 1 time a night. So there's a huge link between obstructive sleep apnea and nocturia, or getting up at night, or making more urine at night as well. So that's another link that a lot of people don't think about, and that's something your primary care doctor can order a sleep study for you that you can either do at home, and then if you need to, go to a center to do it.
Thanks.
And we're going to take one last question from over there.
It is on. Okay. This is first a very easy question for both of you.
Nice.
Will the slides of your presentation be on the Beacon website?
Yes.
Is that a yes?
Yes.
Great. The second one's a little more, you may not be able to answer. But in Canada, they built a new BCG factory. So they have more in the way of BCG production, as does India and some other countries. Why doesn't the FDA? I mean, I know we have this sort of supposedly the premier standard for BCG or our drugs, but BCG is BCG. When will they allow us to use BCG from other countries? That's the question.
Yeah, great question. I'm going to defer to our industry partners. No, I'm just kidding. I don't know the exact reason, but there's a lot of financial implication, and saying that BCG is BCG, that is a hypothesis that needs to be tested and proven. So I think that is in the works, actually. Some of these companies that are developing new drugs are going to validate BCG from other countries in their trials, and then once that happens, then great, we've got more options. But then we're gonna have more BCG. But probably by that time, we're gonna have alternatives to BCG. Hopefully.
So, just to clarify, not in the near term.
Unfortunate. Well, it depends on your definition of near.
Can I just have one quick comment, please, right here?
Hi.
I think that one of the pieces that has been mentioned is constipation causing urinary incontinence. Not everybody realizes how bad that can be, or caffeine intake. Because some of my patients I'll say, what are you drinking during the day? Oh, I'm drinking like 75 ounces of Mountain Dew. And you know, it's a stimulant. So those two things I thought needed mentioned about constipation. If somebody's FOS, you know, there's not a whole lot of room in that abdomen for urine and stool.
Yeah, the bowel and the bladder go very well together. And I'll tell you that before I send patients to someone like Kate, one of the first conversations I have is, you know, you got to be healthy, you got to exercise. A lot of times when you get diagnosed with this cancer, it's not lethal and you're going to live your whole life. So it's an opportunity to step back and take a look at your whole overall health picture. So you need to exercise, you need to eat healthy, stay on top of everything else. And that's just a fact of life. It happens in other things, right? Like I wasn't financially responsible until I had kids. It's the same thing. I don't know if I am still. But some of the most basic advice that I give to patients of what can I do in my diet to avoid these symptoms is avoid caffeine, alcohol, spicy foods, and citrusy drinks. Those are known irritants. I would not avoid any of those things myself, but it's an option.
And everyone is constipated until proven otherwise to me. I'm serious. Everyone is constipated.
Well, we'll have to plan a session around that next time.
Yes.
Okay, so we have reached time, but before we conclude, I'd like to give you both an opportunity to summarize or give us some take-home messages, and really want to thank you for also being here today and answering all our questions. And so who wants to get started with the take-home message?
I guess my take-home is that this meeting is really inspiring. It's nice to see so many people here with a focus on survivorship. And I think that as a field, we're going to be moving more and more towards survivorship because we still are not at our goal of cure for this cancer yet. But our treatments are getting so good that patients can live their whole lives and not die of bladder cancer. It's going to become something like diabetes or high blood pressure. You may need to be on these medications. And there's side effects, but the pros and cons, we can deal with it, and we just have to understand how we're going to deal with it.
I agree. And there's a lot of, my whole specialty is quality of life. So that's what, he takes care of the cancer, and then I'm here to help you live a happier life. So we work together.
Yeah.
Well, help me in thanking them. Thank you so much. So Thank you again. Now we have a 15-minute break and come back for more information and more questions.